like you're a parent, I'm a parent. It's apparent that if kids get a bag of candy, they're gonna eat the whole thing.
Welcome to Primary Care Article Recap for March 2025.
It is so great to be here. My name is Dr. Paul Dillon.
I am Dr. Simon Moore. We are in family medicine, emergency medicine, and urgent care, and we're going to focus on some articles to recap this month. What are they?
So there's 4 great articles. The first 2 are going to be on cough and cannabis.
You got to turn in
ones.
Babies, infants with GERD. What is it? Is it GERD? How do we manage it? And what if it's a red flag? And the last one's going to be
on diverticulitis antibiotics. This is such a hard one to implement, but another great article on this one.
You got it. And if you want to stay up to date with all of the medical literature relevant to primary care in Canada, make sure you think about coming to Vital FM Update. Link is in the description. And we go through all of these in 2 days in an action-packed event. So
let's throw away that cover, dive in. Accidental cannabis ingestion in young children. So this is going to be a child who's going to show up, be a bit sleepy, a little somnolent, lethargic. And you know what? You take a history from the parents and they had some cannabis at home.
You know that, yeah. So you might also be looking for things like congenital erythema. They might have, you mentioned drowsiness. And the
respiratory depression and seizures as well.
Yeah, and these kids need to be observed for 6 hours. And if they're not waking up, they need to go to ICU. And in an American study, that was 8% of kids.
Wow.
Yeah.
I've seen a number of cases of this already in the ER. Now, not these ICU cases, but parents who've had kids who've accidentally ingested some cannabis at home.
And it makes sense. I mean, the regulations for product packaging in America are not tightly regulated. In Canada, it's got to be child-proof packaging. There's got to be warning labels. But a lot of these packages you see brightly colored. They look like candies, they look like gummies, and kids will eat an entire bag and have an enormous amount of THC.
That's amazing how they had to write that in there. Like, you're a parent, I'm a parent. It's apparent that if kids get a bag of candy, they're gonna eat the whole thing.
You got it. So it's fascinating how many calls to poison control there are about this.
Yeah.
We were guessing, what, maybe 5%?
That's like 5%. And there's all sorts of other stuff that kids get into in the house.
Yeah, listen.
What was it?
So in 2020, unintentional marijuana ingestion in kids younger than 5 years of age accounted for 41.6% of poison control encounters.
You almost have your own separate phone line for that.
It's unbelievable. So this is an enormous issue. If you're working in emergency medicine, you've probably seen this. If you're working in primary care, sleepy kid, he's been sleepy for a couple of days, same about this.
Oh, interesting. It's like a reasonable older kid who just doses 1 gummy a day.
It could be.
Is it hidden under his pillow or something?
Could be, yeah. So definitely keep that on your list of differentials. And the signs of toxicity, poor balance, nausea, pallor, loss of consciousness are the signs that we've seen in kids who've taken higher levels to the point that they're achieving toxicity.
Yeah, so I think part of this, the other piece is not just the child presenting, but if you've got someone with kids and they mention in their medication history for something totally unrelated, if they do have marijuana or edible products at home, make sure you're reminding them about safe storage.
Let's move on to our next article. We're going to talk about a fascinating case report. So this is a 74-year-old guy. I love that the genius in this article was not the doctors who elucidated the diagnosis. No, the patient was like, I tried this and my cough got better. And he was right.
He was totally right. So there's a couple of learning points from this one. So this is about a patient who had a chronic cough that was caused by his statin.
Unreal.
Like, what? That is not so bad. He does not talk about other stuff, and it used to be, take it at night, or like muscle pain, and the standard mantra he used to state about statin side effects. Cough was not part of it.
Yeah, so
an ACE, sure, but it was not there for this.
Unbelievable. So this guy, 74-year-old, he had an MI remotely, and he had a dry cough for 15 years. And he worked in an asbestos factory, wire factory, for 20 years. Of course, the doctor's like, no, I know what the cause of your cough is. No other inhalant exposures. He did smoke cigarettes.
Of course.
He had a CT scan showing, hey, it looks like you've got some mild asbestosis of the lungs. Do you want a biopsy? He's like, no biopsy for me. I can picture this patient in my mind. I met this guy, this type of patient.
And he says to you, but when I stop my statin, the cough goes away. And you think through your differential of everything that could be, you probably had GERD as well. Like, what are the other things you have? Upper airway cough syndrome, GERD, asthma, causing the chronic cough. and he tells you, well, when I stop my statin, my cough goes away. What are you going to say?
I'm going to refer you for the emerging fourth most common cause of chronic cough, which is non-asthmatic eosinophilic bronchitis.
Oh.
But yeah, he'd seen respirology, and at the end of the day, they said, well, switch your atorvastatin to bedtime rosuvastatin, cough resolved.
Yeah, so it is a known rare complication. Big picture, what do you want to remember? And this was interesting because he was started on 2 medications at the same time. So generally, if I can, I try to never start 2 medications at the same time.
Oh, cardiologists must hate you.
I know. Yeah, after an MI, I'm like, this is going to be a 4-week inpatient stay.
Heart failure patient.
Or 1 medication.
4 meds. And you're like, no.
But when possible, I think it's a practice tip to don't start 2 medications at the same time, because you're never going to be able to tease out like, A, what's the effect of the medication, especially if you're using them for a similar indication, and then what are the side effects?
Yeah, and you're going to need someone smart like your patient to tell you what the diagnosis is. Amazing. Good for them. Moving on to our next article, common scenario. You're going to see folks coming into ER with this. I've seen folks coming into primary care, urgent care with this. This is a baby with GERD. We're talking infants. We're talking less than 1 year of age. And again, it's probably GERD. Most kids have GERD, but there are things we got to keep in the back of our mind. So we're going to run over management, red flags, and a really helpful tool on chatting with the parents.
Yeah, so when do you get worried? That's ultimately the question with this. Big picture, we're not giving PPIs. You could do some thickening of the feeds, but the features of diagnosis for when it's not GERD. So persistent forceful vomiting, bilious vomiting. You have a crazy use for this.
Yeah, there's an incredible story of a lecturer in UBC, and all these med students at UBC, if you talk to them about green vomiting, they'll tell you about the pediatric surgeon who jumps on a table in the middle of his lecture and shouts, "Beware the baby that vomits green," because it's not normal for a baby to have bilious vomiting. So if it's GERD, but the vomit is green, that is a huge red flag.
Yeah, I had a case when I was working in the Falkland Islands where it was persistent, forceful vomiting. And the mom said, you know what, we vomit, it's really strong. And I was like, does it go across the room? That was the question I was out told. If it goes across the room, then it's pyloric stenosis. And she was like, no, it doesn't go across the room, doesn't go across the room. And I was like, I'm worried. And then she's, I think he's going to do it now. And the reason it never went across the room is she'd take the baby and she'd face him down and it just went bam.
Oh, wow.
Right to the ground. Yeah. And so we actually had to medevac him out. It was pyloric stenosis.
Holy smokes. Okay, so that is not GERD. If it's forceful vomiting, even if it doesn't go across the room. What about that baby with GERD, but also having chronic diarrhea or bloody diarrhea? Huge red flags. We're worried a little bit more about something more serious. And then if, they got blood in their stool, bulging fontanelle, seizures. Yeah, it's not GERD.
No.
If you got those. And it can be tough to tease out because these features are GERD. When the kid's got some wheezing, they've got some irritability, they're not wanting to feed, they're arching or painful during feeds, or they're having poor growth. That should be concerning, but those are all reasonable with GERD. Now, there's a really common diagnosis we need to think about as well. Cow's milk protein allergy. I know Canadian Pediatric Society has just released position statements on this recently. And what's our first step there?
So cow's milk protein, CMPA, so not the Canadian Medical Protective Association, making, if you're suspecting it, first therapeutic step, eliminate cow's milk protein from the diet. And that's a trial, formula-fed infants, a 2-week trial of hydrolyzed formula.
Yeah, I would be specific here though, is it needs to be from the patient's diet, not the doctor's diet. People are going to take these too literally maybe. Now, my favorite part about this article is that they've got the spiel. I was just talking with a colleague in my clinic and they said, I really love to see other doctors and NPs talk to patients because I get to hear their spiel. What did they say to this patient?
Yeah.
And sometimes that's what the learning is, and that's where you actually really understand it. So most infants are fussy and spit up or vomit after feeds. This is called regurgitation or gastroesophageal reflux. It is normal and not a disease.
Well, that's a lovely turn of phrase, isn't it? This is normal. And that reassurance is huge.
Almost all infants younger than 1 year of age do it at least twice a day. And in fact, that's why it's so hard to study, because you enroll 100 kids in a trial for a GERD treatment. After 6 months, almost all of them will be improving anyways. So it's hard to tell, was it the treatment or was it they're just growing up? Any other good ones that stood out to you?
The infant's intestinal tracts are immature, and as babies grow, the valve between the esophagus and stomach will strengthen. The baby will also be increasingly upright. All of this will help the regurgitation to subside.
Yeah, and I love, these folks are clearly very experienced. Parents coming in, well, we need that medication. My other child Even a couple of years ago, they had a medication to reduce the acid. There's the H2 antagonist. You've got your PPIs as well. And we're not recommending those anymore. The guidelines are saying we don't think they help. And there's risks. What kind of risks?
Risks, so infectious risks. So increased pneumonia. You can have gut dysbiosis.
Indeed. So what do we say to the parents? They say drugs do not affect the fussiness or spitting up. They don't help. Medications for GERD reduce acid, and acid is usually not the problem in infants. And so all medications have side effects, so best to avoid them unless necessary.
And then close follow-up. Invite them to come back. We'll see how you're doing again in a month.
That's great. So wrapping up GERD, and we've done the recap on reflux.
Yeah. And now
more article.
we head to the end.
And
The end.
go to
We've done GERD. We've done cough. What about that back end? Diverticulitis. You've got someone coming in. They've got a bit of a white cell count in the ER. They've got some left lower quadrant abdominal pain.
maybe some diarrhea, maybe even some bloody diarrhea. Get that CT scan.
Diverticulitis. And antibiotics.
Oh, that was ciprofloxacin. That's all we did on my surgery rotation in med school. And patients who've had this before,
Yeah.
those are the hardest to convince that we don't do that anymore, because they're like, I've had this 100 times. Every single time my doctor gave me ciproflagyl.
Simon Moore every single time.
So first of all, what population are we going to say, no, you do not need antibiotics?
So who are we going to pause? To not give antibiotics?
You got it, yeah.
So it's going to be everyone other than those who are frail or immunocompromised, who have uncomplicated. The key thing is the CT scan. Where this gets tricky is if you don't have a CT scan.
Yeah, so that's why it's so important to get a CT scan and to look for those complications. And what sort of complications are you looking for in CT?
So you want to see if they have an abscess, if they've perforated, is there some evidence of a complicated diverticulitis?
Yeah, so frail, immunocompromised, and complicated, those folks do need antibiotics. The rest of them, well, good luck. Have a conversation. There's no spiel in here. I wish there was spiel in here. Most of these patients will improve without antibiotics, and antibiotics do not alter early complication or recurrence rates.
Yeah, so anti-inflammatories for these patients, and then close follow-up. If something changes, they need to come back. You need to see them again.
Education, and then just expect that they're going to go off to another clinic and beg for antibiotics, because that sometimes happens. The nuts. This portion is so interesting because, again, in medical school, I was taught.
What was the spiel?
The spiel was, do not eat nuts or seeds because they're going to get into your diverticuli and cause diverticulitis.
And the evidence says that spiel is wrong.
It's true.
It's a non-evidence-based spiel.
I love the up-to-date article where they say the authors have scoped thousands, if not hundreds of thousands of colons with diverticuli, and in every single case, we've never seen a single nut.
That's crazy.
That is nuts. So that is Primary Care Article Recap. We do this every month. Please like, subscribe, because we want to help keep you up to date so that you are giving the most recent evidence in your care to your patients. And why don't you talk about one other way that people can come and get some vital updates?
We are going to be doing a weekend of incredible updates, vital updates for family medicine in Toronto coming up this year. So excited to be doing that.
You got it. So family docs, NPs, primary care, and welcome to Canada. We got new physician assistants coming to Canada. You're all welcome to join us at Vital FM Update. We hope to see you there.